Hey everyone, welcome to The Scoop on being a cancer dietitian. Let me invite my special guest for the day. Caitlin Benda is going to be joining us. And we have not done these before. I will say thanks to my intern Amber, who helped plan a lot of these sessions, and to talk to some other talk to some other dietitians in training, RDs to be, and dietitians actually in general, help fill out a survey to find out what it was that they wanted to learn about being an oncology dietitian. So we are kicking off this interview series with Caitlin. Welcome, Caitlin.
Hi, thanks so much for having me. Can you hear me okay?
Yep. So I don't know, I didn't plan an intro for you, but this is Caitlin, and she is an oncology dietitian. She also has an MBA, and she is the past chair of the Oncology Nutrition Practice Group. And that's how I mostly got to know her. But actually, I live in North Carolina. She lived in North Carolina at the same time for a while, and then moved all around, I think.
Kind of. Yeah, I was in Charlotte and then moved back up to DC. So I've been back around Northern Virginia for the last 4 years, which is where I grew up. So.
Okay, awesome. Well, so our theme for today is the daily duties of an outpatient oncology dietitian. But I wanted to start with Caitlin, you just sharing some about your training and your job itself. So, I guess, what kind of training did you have to go through to get your position, and where is it that you work, and what do what's your position there?
Sure. So the training that I went through, so of course I had a bachelor's degree, and I got my bachelor's degree in nutrition and in psychology. Initially, I wanted to work with eating disorders, and then found out that was not the field for me when I was in my dietetic internship. I really didn't have much oncology exposure in my dietetic internship, but really fell into the field of oncology in my first job when I was working as an inpatient dietitian on a GI surgery floor. So I was really exposed to a lot of inpatient oncology then, and just a lot of different fields in general. But I also got my master's in nutrition at Tufts University, did that at the same time as my dietetic internship. And I then started my first job. So specifically to oncology, in order to be an oncology dietitian, I had to get 2,000 hours of field-specific experience in oncology prior to sitting for my CSO exam. So that was kind of the most oncology-specific experience that I had. But every job that I have had since then, the CSO has not been required, but it has definitely been preferred in order to be in the position I was prior to the current position that I'm in. So my current position is a little bit unique. I am an outpatient oncology dietitian, but I work remotely, and I see patients at clinics with American Oncology Network, so community oncology clinics, and I cover clinics in Maryland, South Carolina, and Georgia. And then I also supervise our oncology nutrition team that is made up of 6 dietitians, including myself, that see patients all across the country, all remotely. So it's a little bit of a unique position that it's remote, but still in the outpatient setting.
And so when you supervise them, they're remote, right? Like, are you supervising people in a geographic area, or supervising dietitians who are working with a certain population set, or how do they break that down?
So it's distributed geographically. So there's dietitians, we have a dietitian that lives in Colorado, one that lives in Indiana, one that lives in California, one that lives in Philadelphia, and one that lives in North Carolina. So kind of where the dietitian is located, for the most part, that dietitian covers clinics within that same time zone. But it can also be different, because, for instance, our dietitian that lives in California covers the Ohio time zone, so the Eastern time zone. So really where the patients are distributed, though, is based on their geographic location, so that a dietitian isn't covering 2 different time zones at once, because that would be a bit of a mess.
Yeah. So, and then are all of your dietitians CSOs, the ones that work on your team?
Yes, all of our dietitians are CSOs, which I think is fantastic. One thing that's nice about kind of where I am now, and one of the big incentives to me with this position, was that everything, because we weren't limited to a geographic location. For instance, I worked in Fairfax, Virginia previously at the Innovashar Cancer Institute, and we were limited to dietitians that could come to be and work physically in that location. So now in my current role, we kind of are able to have access to dietitians from across the country that specialize in oncology and don't necessarily have to work within driving distance of those clinics. So that has been a really great asset to be able to make sure that we're getting really experienced dietitians to cover the oncology patients at the clinics that we're seeing.
Yeah, so I think that's a good point for people who are on who aren't CSOs yet, that there are ways to be an oncology dietitian, because it is a lot of hours to get. So, you know, if you don't, like when I think I took the first exam that was offered, and I was working at an outpatient cancer center at the time. So all of my work hours counted. So, you know, it took, I don't remember, a year or two or something to add up my hours. But if you're somebody who's only doing oncology some of the time, it can take a while to get those hours. But there's still ways for you to work as an oncology dietitian, even if you don't have your CSO yet. And, you know, in job interviews, you can always tell them, I'm planning to get it.
Absolutely. That's I work with some mentees that are students. And one thing I always encourage is trying to get involved, trying to make sure that you're kind of gathering this and you're putting in your bucket oncology experiences, so that if you don't have your CSO and you know you want to be in a cancer center or working as an outpatient oncology dietitian, that you can share with them all of these great things that you've done to kind of support your interest in the field without having those specific hours.
Yeah. So we've had a couple of shout outs in the comments. Someone whose mother-in-law used to work with you in Charlotte. And Jamie, who I think is one of our own DPG members, also said
she is, and she's one of my mentees. So she is one
awesome.
of my student mentees. Yeah. Hi, Jamie.
Cool. Okay, so you're full-time, obviously. And what other career opportunities do you see for future dietitians interested in oncology dietetics? So let's say they're interested in it, they don't have the job yet. What kind of, like, if you were going to hire a dietitian onto your team, and they weren't coming from a cancer center already, like what kinds of things would you look for on their resume?
I think definitely just kind of that passion for oncology. That is one of the biggest things. I feel like as oncology dietitians, we're this very kind of, I think, an amazing group of individuals. I know when I started working with the DPG, I was like, oh my gosh, I found my people. Like this is wonderful. Hence why I've never left working with the DPG. But one thing is just really that passion, that compassion for other people, that willingness to kind of put yourself out, and really that being able to empathize with patients and try to make sure that you're able to handle the stress of the position and kind of the stress of the job that we do, because it's not always happy work. A lot of times it is very happy work and it's really rewarding work. But that passion is something that I feel that when I've hired before, you can just kind of feel when somebody's the right fit, when they exude that passion for oncology nutrition, and you know that they will be successful in the field. I think something else is just opportunities. So different things that within our current job that we're working on is bringing a virtual wellness series to the teams that we work with across the country. So using that to educate staff, using that to educate providers about the role of oncology nutrition, and also kind of discerning what's fact from fiction when it comes to oncology nutrition. Because a lot of times I feel like I am the one that is kind of busting myths all day long, as I know you're familiar with also. And so kind of using that as an opportunity to educate teams and providers where they may not have had and likely haven't had that education previously. I think also bringing different opportunities to patients, whether it's cooking demos or whether it is different educational seminars, having that ability to be creative in the way that you approach patients and really working to find things that work well for patients is something that I think is a huge asset to somebody who wants to be an oncology dietitian. So creativity, empathy, passion, compassion are really, I think, key things that work together to make an awesome oncology dietitian.
Yeah, oftentimes when I'm like interviewing potential interns or even volunteers, I always often ask like what their experience is with somebody who's had cancer, whether professionally or personally, because yeah, you have to have that. It's helpful if somebody understands like what type of journey someone has gone through, or they've experienced it themselves or with a loved one or, you know, a friend or something, so that they can really sense, you know, and be that compassionate kind of person walking alongside them and not just, the clinician. But I'm with you. Like, I feel like oncology care providers in general are just kind of a special group of people. And
I agree.
Typically, the teams are really supportive of each other and very supportive of the patients, and the patients are generally like very grateful kind of, people for the care. And so it's sad sometimes, but it's also a very happy kind of environment to be in. Okay. So on a day-to-day basis, what kinds of tasks are you doing throughout your day?
Can you still hear me okay? Because my headphones down. Am I echoey?
No, it's fine.
Okay, I can move if I need to. Just let me know. If you guys can't hear me, just let me know. So day to day, one of the first things that I do is screen patients. So we do use the malnutrition screening tool. It is hard in a virtual setting because I'm not in the clinic to kind of remind people. So that's something that's been a challenge in my current role that I didn't have to deal with before. But I do screen patients. We use the MST. We also kind of screen based on diagnosis, treatment regimen, and then are looking to put in consults or put in referrals for those patients. Currently, I do reach out to patients on my own for scheduling. We do have scheduling. The clinics are supposed to be scheduling for us, but the efficacy with which that has been working has not been great. So in an effort to get patients seen, we are kind of piloting some different options of trying to reach out to patients on our own, which isn't necessarily working at the top of your license as a dietitian, but it's something that it's a nice opportunity to connect with that patient, explain a little bit about what you do. Because a lot of patients will think, I don't need a dietitian. And then once they talk with the dietitian, like, oh, maybe I do need to talk to somebody. Or, oh, you're not just going to tell me to eat kale all day long. You're actually, have some good advice and some good tips and tricks. So for the most part, once I spend the most of my days, I have 3 clinical days a week, 2 admin days a week. So on my clinical days, I'm mostly seeing patients either virtually via phone, virtually via telehealth. I'm working with them through a variety of different issues, whether it's that they are starting on treatment and have nutrition issues kind of at that point, kind of following diagnosis prior to starting on treatment, whether we're kind of navigating some nutrition issues that are occurring while somebody's on treatment, more like symptom management, again, trying to be creative with ways to make food sound appealing when food is the last thing that you want to be thinking about at that time. And then also in survivorship and talking more about things that really we believe can reduce risk of recurrence. So that's been something that in my previous job, I mainly dealt with patients with upper GI cancers. So I didn't focus a lot on survivorship, but that's been nice in my current role is that I get patients with all different types of cancer. And so finding out different ways to provide that information to them and help to be an advocate for them so they can help to try and implement some of those guidelines within their kind of own habits and own lives.
Cool. So,
and aside from that, go ahead.
So you're saying that's 3 days a week, right? That you're doing clinical work. So on the 2 admin days, like what kinds of things are you working on?
So I'm doing things, a lot of meetings usually, connecting with my team one-on-one, connecting with my supervisor one-on-one, especially because I can't just stop by somebody's desk and show off pictures of my kids or ask them how their weekend's going. So that's something that I think, especially in a remote environment, is so important. And I feel very lucky that our team, I've been with the company for 3 months, and I think that our team really feels like a team. And that's something that just to me is so important because we're all working at home on our own, but I still want to make sure that we have that connection and we have that ability to rely on each other to troubleshoot ideas or to bounce ideas off of patients or bounce ideas off of each other for patient care. That's something that's really important. Other than that, I'm really big on productivity and not necessarily on like trying to make sure we're being like productive per the numbers, but I really like statistics. I really like monitoring trends. I really like spreadsheets. Anybody that's on the call that knows me knows that I love Excel. So I'm usually trying to pull data, and that data that I'm pulling is not necessarily to track and see where my dietitians, if they're being as productive as they should be, because we don't have any benchmarks, but just something I'm passionate about and hope that at some point in my career, I'm able to help with establishing some benchmarks for where dietitians working in outpatient oncology should be, or kind of ideally should be. But we deal with a lot of different things and a lot of admin sometimes, and that doesn't always play into that direct patient care percentage. But I'm pulling those numbers really with the goal of trying to advocate for additional positions, redistribute work if needed, and just make sure that my team is running as efficiently as possible. And performance evaluations, chart audits, answering questions. So really just kind of daily admin, kind of managerial responsibilities, connecting with Abbott reps, connecting with other reps, trying to make sure that my team, that the clinics have what they need, and making sure that we're able to get patients what they need kind of from a virtual setting as well.
Yeah, it is a lot harder to manage a team, I think, or to have a good team dynamic when you're not physically in the same space, because there's no drop-in times, and being intentional about like one-on-ones and just getting to know people even during that time, not just talking about work, that things about people and they live somewhere completely different. It's hard to like get your mind around that, but that seems really important. So you mentioned like in some of the skills that people might have, even if they're not CSOs or oncology dietitians already, that kind of getting people on board or doing education programs. So I think that a lot of what we as oncology dietitians struggle with is making sure that the other healthcare providers understand our role and also how important it is that they utilize the oncology more positions. So is there anything that you have found that's been especially helpful when you're trying to get other oncology care providers on board in understanding how important nutrition is?
I think it really depends on what type of provider. If you're talking to a physician and trying to get the buy-in from a clinician, from a physician or an APP about really the importance, data, research is really kind of that most important piece. Also just them having had, if you can get their buy-in once and you can get a patient that says, oh my gosh, I met with a dietitian, it was so helpful, you've kind of got them hooked for life and they're going to start sending everybody to you, or kind of being that bug in their ear. And that if there is something that you disagree about, that if you have a provider that is telling patients that they shouldn't be eating sugar or they shouldn't be eating soy because it's making their cancer worse, having a professional conversation with them. I think that I've had a really great experience just in general throughout my career where I've been able to work with providers that really value having the oncology dietitian as a part of the team. So there's been a good kind of collegial relationship where it's not that they're the physician, I'm the dietitian, and I'm coming in underneath them, but then it's a conversation that if we're talking about something like maybe starting somebody on pancreatic enzymes, or do we need to be looking at a feeding tube? Do we need to be looking at alternative ways to get nutrition? It's having that conversation and not coming in scared to ask them about something and more saying, hey, this is my idea. What do you think? Let me get your feedback, and having that open conversation. I think when it comes to other providers, nurses are a huge advocate. Our nurses, I feel like, are oftentimes the way that we get referrals, because they're having this, oftentimes if somebody's there in chemo, the nurse is there, they're there for a long time, and they're going to tell that nurse things that maybe they wouldn't tell the provider. So a lot of times the nurses are a really good source of information for the patient, but also a good source of information for myself as the dietitian. So trying to make sure, I feel nurses are definitely, science background and research is also important to them, but I feel like giving nurses information that's more like things that they can share with the patients that maybe is basic level. And then it's like, you're basically telling somebody, where protein is found, but then they know that they can send a referral if the patient needs additional information and knows that, and there's questions that they aren't able to answer. So just trying to maintain that kind of open attitude, not coming in like a know-it-all and not wanting to tell everybody what you know, but having that open conversation and staying open-minded as well.
So it sounded to me like you said, enter a meeting with the physician with your data and your confidence and your know-it-all attitude, and then approach the meeting, with the nurses and not a know-it-all, like, how can I help you kind of.
It is, definitely. Because the nurses, they're looking at you, anything, they're busy. Everybody's busy in clinic. And so it's like whatever you can take off of their plate. If you come and you say, hey, that you were worried about trying to refer patients, let me get these referrals for you. Let me take care of this. And they're going to be much more grateful to you and much more likely to refer if they see what you can bring to help them.
Interesting. Awesome. So, okay, we're going to move into part 3, and anybody who's on that has questions, you can put it in chat. I'm trying to write them down because I can't figure out how to go back to the chat. So anything I see of interest, I've been writing it down if I noticed it. But if you put a question in already, just go ahead and put it in again because I missed it. So the third part, which is kind of my favorite, is to let dietitians rant. So my question to you is, what is the most annoying part of your job? Or I don't know, you mentioned some of the myths. Like what's kind of you wish was not part of your job, but it is and it's gonna be, and that's just how it is.
I wish that there's a degree of the myth busting that I enjoy, that when a patient comes in and they really see you as the expert and they're willing to listen. But where I'm challenged is where somebody it's like they look at nutrition as a religion, and you're literally trying to convert somebody's religion. And I used to talk with one of my colleagues in my previous role, and we used to say, gosh, if I had known that we were going to go and try to convert people's religions, maybe we would have gone into something else, which I don't regret being in oncology or being a dietitian at all. But it's hard because you have people that obviously we believe in the power of food, but we're also realistic about what food can and can't do. And so trying to go in with an open mindset to those patients, thankfully they're few and far between. Most people are pretty open if they're seeing you, but really trying to find ways to skirt around the information that's out there that is just so blatantly incorrect based on the research and the evidence that we currently have, and trying to rationalize with those patients, what we can do with nutrition and what is really achievable. I think one of the biggest things with working with them is not going in with any judgment, staying open to hearing what they're going to say. Really listening is key, because oftentimes you're able to find that there's pieces of what they can use or what they're using to make those decisions that you can use to kind of bring them to your side of the table, or find things that they're willing to change and use that kind of research with them. Because oftentimes these are people that are doing a lot of internet searching, doing a lot of Googling, and are finding information. So that's, I think, one of the hardest parts is the myths and just the misinformation that is out and available readily today all throughout the internet.
Yeah, I'm with you on that, because sometimes it seems like I can't even get to helping somebody with the important stuff because we have to wade through all the myths first. Mm-hmm. Okay, we've got a couple questions coming in. I need to write this last one down. Well, let's do the last one first so I don't have to write it down. With the MST, do you find you get too many unnecessary consults? Like if they're not sure if they've lost weight and they get triggered to see you, and then you're like, okay.
So our current cutoff for the MST is 3. So with the unsure question, if that's the only thing they're answering and that puts them at a 2, I know per the actual MST guidelines that is nutrition risk, but we did ours at 3, mainly because American Oncology Network was previously part of Florida Cancer Specialists, and the nutrition team from there had decided that the 2s were getting in too many of those unnecessary consults. So if we ever did move to 2, what I would kind of use it as is more of like as a, not necessarily like this is a referral that you absolutely have to complete, but contacting that patient and kind of doing an additional level of screening to be able to say, hey, are you eating okay? Is there just something that maybe they weren't sure, but they're eating okay and they're not having any symptoms, and you can provide them with your contact information and remain available to them as needed throughout their treatment, but not necessarily need to go in and do a full-blown nutrition assessment. I know as dietitians, we're often hungry to get people the right information and to share information with them. So we want to make sure, I know I'm guilty of it myself, of throwing all of this information on them right in the very beginning and not really assessing where they're at and are they ready to receive that information. So if you are kind of able to screen them additionally at that point and go in and then they would reach out to you if there is an issue by providing your contact information. So right now,
so they would get like screened with the MST, which is a paper screening. And then if you're doing, say, 2s, you might get some more people that need to be phone screened or something by the oncology dietitian, and then maybe decide after that if they need a full nutrition consult or assessment. Absolutely. Which is interesting because I work in a nonprofit setting, so I'm not in the clinical setting anymore, but I get clients who call me with questions. And I would say now that we're having this conversation, that's what I do. Is I basically I'll talk to them on the phone. I don't have access to their medical charts. So I give them some basic tips, but it's sort of this screen where I might then refer them, suggest they talk to their cancer center dietitian for a full assessment. So somebody asked, is MST different from NFPE, which I believe is nutrition focused physical exam, which I was not taught in school because it's kind of newer. So if it's different, how is it different?
So the MST is more of a nutrition screening where you're trying to just go through and find those people that are at higher risk. The nutrition focused physical exam is part of an assessment where you're actually looking at the patient's physical changes in body composition to assess their nutritional stores, their nutritional reserves, and their risk for malnutrition. So the screening happens prior to the assessment, whereas the NFPE is part of the assessment.
And the screening does not require touching people?
No, the screening does not. It is just two simple questions. Our doctors do it, our MAs do it, our chemo nurses do it. So oftentimes it's not even a dietitian doing it. It's either somebody getting a piece of paper or they're being asked those questions.
But do you do NFPEs?
It's very hard. Most of my visits have been on the phone, which it's very challenging to see, touch, feel somebody, in that setting. But what I found is that when I started working at home initially during COVID or the beginning of COVID. And there's a lot of ways that there's questions that you can ask in order to have patients describe their physical changes that can help to lead you to kind of that assessment as to whether they're having muscle wasting or fat loss. So I don't use, if I'm diagnosing somebody with malnutrition, I don't use those changes as part of my diagnosis because I can't physically see the patient. Even if they're on Zoom, then I might be able to use like temporal wasting or like wasting in like the upper body, but it's not something that over the phone I really am able to do. So oftentimes when I do it, I'll say likely has mild to moderate muscle wasting based on patient's description of physical changes. But I try to use the other characteristics in terms of diagnosing malnutrition more than that, the actual physical changes.
Are other team members, like, do you ever use the nurses or the doctors to give you some of those more, because they are with the patient? Do they ever give you that information?
Yeah, I'll review the chart, and if they say patient looks cachectic or, has muscle wasting, sometimes they'll put that information in there. So I will also pull that into my assessment if I'm able to find that information within their assessments.
Okay, we had another good question. Is soy okay for cancer patients?
Yes. Soy is okay for cancer patients.
We like you to eat, tofu and edamame and all of that. So yes.
Yeah, it's right nicely with the based diet.
So one other question that came through, is it difficult to get more dietitians or support staff hired?
It definitely is, and it really depends on the size of the organization, has been my experience. So in my previous role, we were very busy. We desperately needed additional staff, but the people at the top making the decisions, people that control the dollars and the funds, they wanted to see data. And we had good data about the growth, but it has to go through a lot of channels. I haven't encountered the issue of needing to hire support staff or additional dietitians yet in my current role, but I anticipate as we grow and as we add more clinics on, that we will. And that same data to me is just absolutely what's essential, because oftentimes it's not a dietitian. Like, there's not a dietitian above me. So I'm having to advocate for my team to my manager, who is a nurse, to her manager, who is a previous office manager or clinic manager, up to, the head of the entire company, to get that additional staff. So the more data, the more hard numbers, the more that I can show that this is why my team needs something, that is very helpful information in order to get that support staff. It doesn't always work, and you have to keep advocating, but I'm a big advocate. I feel like I'm repeating myself, advocating. I'm a big advocate of having people understand what you do and the benefit that you bring is huge to help with that.
Yeah. And, still not reimbursable services. So
yes,
I got lost there. Sorry. So I would say the DPG is working pretty hard, and there's a lot of other oncology dietitians that are working pretty hard on trying to gather enough data and advocating at the sort of insurance level to get reimbursement, which would also help. But there are plenty of other oncology support staff jobs that are not reimbursed. So it's not like we're the only ones, and they're able to be staffed. So that in itself is not a full excuse, but it certainly does make it extra challenging.
Yes.
All right. I don't think, did we get any other questions? I didn't see any other questions in there. I want to kind of wrap up today just asking Caitlin if you have any maybe one or two pieces of advice for those who want to be an oncology dietitian or want to move towards that way, whether they're in school or they're early in their careers and kind of or maybe they're late in their careers. I did have someone comment on the post that they are a dietitian who is a cancer survivor also. So I think that's really interesting. So any advice that you have?
I would say I'm biased towards the DPG, but I would say get involved. It's one of the best things that I think I've done in my career. It's offered me so many opportunities that I wouldn't have had otherwise, and it's helped me to grow both personally and professionally. So not only the information, I think if you're a student, it's like $5 or $10 to join, but the wealth of benefits that come out of the DPG for even the regular active member fee is so worth it. So it's such a great organization, such a great group to be a part of, and the more involved you can be, the better, again, that goes to show it makes you stand out, it differentiates you on your resume versus the next person. The other thing I would say is look for opportunities in your community. So I know that one of my colleagues where I was previously, there were no oncology dietitian positions, but they had community resources where they wanted a dietitian to do classes. And they weren't paid, but she did classes, she provided information, and they saw the value in what she did, and they created a position for her, which then led to the creation of my previous position. So however you can get involved, looking towards local nonprofit organizations, cancer centers, seeing if there's any gaps that they have that you can fill, kind of in outside of what your standard job is or outside of your current role, then that's a really great way just to, again, enhance your resume and show that you have this passion for oncology and this interested in being more involved in the field.
Great advice. Well, we are going to wrap it up. And Caitlin, I'm so thankful that you joined us today and kicked off our first session about this. And for everybody who's on, if you have thoughts about what questions you want answered, I believe my next session, I'm planning to focus a little bit more on the screening process, the tools and that kind of thing. So that's the plan. But if you have other thoughts, any of you people on, we would love to hear it. Thank you, Caitlin, so much. Have a great day.
You're welcome. Thanks, Julie. Bye, everyone. Thanks so much.
Bye.